Good evening. I'm Dick Deming, Medical Director of MercyOne Cancer Center and founder of Above and Beyond Cancer. Welcome to this week's edition of the Cancer Education Series. It's brought to you in collaboration with Mercy Cancer Center and Above and Beyond Cancer, and it's funded in part with a grant from the Iowa Cancer Consortium. And you guys are in for a treat tonight. I know I'm in for a treat tonight. I have a friend of mine from the National Cancer Institute who is going to be having a conversation with me, and we're going to be talking about research in cancer. So let me introduce you to Kate Castro. Kate is a fellow Dakotan. She's from North Dakota. As many of you know, I'm from South Dakota, but we're all friends up in the Dakotas. And Kate grew up in the center of North Dakota and then got her nursing degree at the University of North Dakota and her master's degree at the University of Minnesota. She's been an oncology nurse for 30 years, and she currently serves as the nurse consultant and program director for the Healthcare Delivery Research Program at the National Cancer Institute. And we're going to talk about cancer research, and some of what we're going to talk about might be surprising to you. Most people think of research as either being in a laboratory, mixing chemicals, or providing different sorts of cancer treatments to patients and comparing one to the other. But there are other types of clinical research that's being done in cancer. And with that, let me welcome Kate Castro. Kate, thank you so much.
Thank you, Dr. Deming. It is a pleasure to be here, and I wish I could be there in person because, as you said, home for me is North Dakota, so being back in the Midwest is always a pleasure, and I do appreciate the opportunity to be with all of you this evening.
And Kate, as you know, and for those who are watching this, are going to be watching it in the future, it's December 1st today. We're going to hit 70 degrees in Iowa tomorrow. So it doesn't feel like Dakota in December.
Well, wait till next week. You know,
Yes.
If you don't like the weather today, you just wait a week and it'll change, or a day, actually.
So I've asked Kate to give a little bit of a presentation. Let me just load your slides here, Kate, to kind of set us up for our conversation this evening. Kate and I actually got to know each other, probably 10, 11 years ago. MercyOne Cancer Center was participating in a program, the NCCCP. It was the National Cancer Institute's Community Cancer Centers program. And we now collaborate together with the National Cancer Institute Community Oncology Research Program. And I've asked Kate to give a little bit of a background about cancer care delivery research. So Kate, I'm going to turn it over to you, and I'll advance your slides. You just let me know when to move forward.
That's terrific. Thank you. So again, it's really a pleasure to be here this evening. And I want to just highlight, as Dick said, we are part of the National Cancer Institute and part of the National Institutes of Health. I'm pleased to say that we are celebrating our 50th anniversary of the National Cancer Act this year. So you see on our opening slide, we have the logo for the 50th anniversary. So 50 years since we have been moving forward with cancer research. And I hope this evening we're going to talk about an area of research that was newer to our group within the past 10 years as we started what we call the NCORE, which I'll talk a little bit more about. And it really is a different twist to the research. And I think you'll find that it is something that really is a very important part of the work that we're doing and really critical for making sure that our patients are getting the optimal care that they so richly deserve. Next slide, please. So the NCI Community Oncology Research Program, and I'll refer to it as NCORE, that's our acronym for it. We love our acronyms in the government, so that's our NCORE acronym, is a national network of centers across the country that do our research studies. So we have 7 research bases that design these research studies and work with our sites to determine what are the best ways to do this study. Is it feasible to be done in a community setting? And then roll those studies out to our community sites across the country. And you see on this map here all sorts of different places across the U.S. So the example is our team here at Des Moines is one of the centers that does the research that we fund. So these studies, again, funding comes from the NCI, and then studies go from the research bases out to the team at Mercy for them to choose from. So we have standard studies that you would most commonly think of the research being comparing a new drug regimen, or maybe looking at a new treatment to treat a symptom or a side effect of the cancer itself. However, we also do a lot of other research. So we do cancer prevention studies. We look at different symptom science studies that could potentially not be including a drug, but an intervention such as yoga, or maybe a different sort of a therapy to help with insomnia, sleep disorders. And then a type of research that I'm going to be talking about mostly today, which is called cancer care delivery research. So as you can see, this program is large. We are across almost all 50 states. We don't have a site in West Virginia, and also we do not have a site in in New Hampshire and Vermont right now. But otherwise, you can see dots all over the U.S. here, including in Alaska. We have an affiliate in Guam. We have a site in Puerto Rico and a site in Hawaii. So we are expanded all over the United States. And one of the things that makes this really terrific is that we have an incredible amount of diversity. And that's what's really so important in the research we do, is to make sure there are diverse populations, so that when we get an answer or get a result, this can be generalized more so to the public that's receiving the treatment. Now, you will see different blue dots here and orange dots. And for this map, that actually is a designation of the blue dots being non-rural and the orange dots being a site that we have classified as rural using one of the government designations. So you can see in Iowa a lot of orange dots, and we're very proud of that, because the goal of this program is to bring research opportunities for cancer patients to their home communities. So you do not have to travel so far to get the research opportunities that you would have, get if you went to Iowa City, to the University of Iowa. You can get it in your home communities and be treated by team members that are right there with you at home. So that's really our goal, is to bring this research to you in your home areas, and to reach out to rural communities is really very important to us. And so we're very pleased to have all of the orange rural sites that we have as well. So on the next slide, I'll tell you a little bit more about our network and why we're really passionate about this. This network has a lot of strengths. We call this our laboratory, really an incredible research laboratory. It's very heterogeneous. So we have sites, as you saw, in the Midwest, our site in Iowa. We have sites in Puerto Rico, New Mexico, that might be dealing with a lot of Native American populations. We have sites that are in areas that are more urban. And so we're looking at what are the barriers and facilitators to the care that you receive in an urban environment. We have people from lots of different backgrounds, and also clinicians that are reaching across a lot of different populations. So it's a very heterogeneous network. We have larger health systems, we have smaller practices. So the care delivery system itself is very heterogeneous as well. And one thing that's really important is the clinicians in our network collaborate in the designing and the conduct of these studies. So Dr. Deming works with our research bases, goes to meetings that our research bases have, and this is where they get feedback from the sites to say, that's not reasonable, that's not feasible, we can't do that, that's not something my patient population is going to do. And that's really important. Also bringing I need this study, my patients need this, what are we doing in this area? So that the research bases really have this collaboration with the clinicians, and that's so incredibly important. In our area of work that I'm going to talk a lot more about tonight, and that Dick and I will be talking about with you, is this cancer care delivery research, where not just the patient is the person that we study in the research, but we have the capacity to study clinicians and also the organizations that you're receiving your care at. So some of the things that affect the clinicians and these organizational variables. We really want to make sure that we can integrate this research into clinical workflow. It's a large part of our feasibility assessment we do is, how does this flow so that it works well? Some of the things we think about, or sometimes we start designing the studies and we get very scientific about it, and we say, well, the patient will come in every 4 days and have blood drawn, and it's very easy for the clinician to step in and say, no, they won't. Yeah, no, that's not realistic. We're not doing that. So how do we make sure that this really integrates into the workflow so that this is reasonable for the patients and for the care system to be able to deliver the research? And then, as I mentioned before, we have really access to a large number of diverse populations, all the way from diagnosis through the survivorship continuum. So the network has a lot of strengths, and we call it really a premier research laboratory when we refer to it at the National Cancer Institute. So on the next slide, we are going to talk specifically about this area of research called cancer care delivery research. And this is where we're really trying to improve the patient outcome or patient well-being. But where we're putting the intervention or trying to change something could be at the patient level, it could be at the clinician level. So we might not be doing anything with the patient, but we might be asking Dr. Deming and his partners and nurse practitioners to be the ones that are actually having the research done on them. Or we could be asking that practice or their organization to be making some changes. So we might look at all of them together. We could look at patient, clinician, and organizational factors. And ultimately, we want to influence and improve the delivery of care. And our work is always looking at understanding and addressing health disparities. That is a thread throughout all the work we do within NCORE, and disparities is something that we're always really, really in tune to and want to make sure that we're addressing. So thinking of trying to reach these different populations and maybe looking at intervening on what we call multiple levels or different places, it's really important for us to get a sense from the clinical teams of what are the important questions that they have as well. Next slide, please. So again, who participates in these studies? Lots of our studies have patients that participate, and some of you may have participated in some of the studies that the Des Moines team has done. Sometimes we ask caregivers to participate, or we'll have what we call a dyad, a patient and their spouse, or a patient and their caregiver that will participate in the study. Sometimes, again, the nurse practitioners, the physicians, or the physician's assistants will be the participants in the study. Or it might be your research nurses or nurses caring for you in the oncology center, your pharmacist, your social worker, or the actual practice itself that we will be getting information and data from. And then sometimes we also have larger healthcare organizations. So very different from what you're used to in traditional cancer research, where it's mostly the patient receives a treatment and you look at the effect of that treatment. Here we can have lots of different participants that take part in our studies. Next slide, please. So when we look at our portfolio of research that we have and our protocols that we have, we address a lot of different care delivery gaps. And one of the most popular ones is looking at guideline adherence. So when you're thinking about guidelines, you're thinking about national guidelines. So you might be familiar with maybe the American Society of Clinical Oncology will have some guidelines that are in place, or there might be larger bodies that will put out guidelines, the U.S. Preventive Services Task Force for cancer screening and such. So these are guidelines that are set based on research, based on evidence that's come from previous studies. And we want to make sure that that's just not going into a paper and nobody's paying attention to it. Instead, how are we implementing these guidelines? Because that's been determined to be the way that we want care delivered. So we want to make sure that that care is really being done that way. So how do we make sure people are adherent to the guidelines? Health expenditures is a very big area for us as well. We've got 5 studies that are looking at health expenditures. I'm very pleased to say in NCORE, in our cancer care delivery profile, we have done multiple studies looking at financial hardship. So we have done some studies that just are understanding financial hardship to learn more about what patients are experiencing, all the way up to a recent study that just opened where patients and their spouses can enroll on a study and receive financial navigation throughout the treatment experience. We also have a study that is looking at parents of children who have cancer, and what is the financial hardship that those parents are experiencing. So we think this is a really important topic. We know you're hearing a lot about it in the media, and so we want to make sure that this is at the forefront of the work we're doing so we can better understand this. Then you can see there's other areas like understanding accessibility of health services, case management, and how do we best provide good management and oversight for patients as they move through systems, shared decision making. We have a couple of studies that one for breast cancer patients, we had one for prostate cancer patients, where you used a shared decision making tool before you go in to see your doctor so that you can then see how that tool either benefits or does not benefit you in your conversations that you have. And also a study looking at drug utilization. So a lot of different areas where we're kind of doing some work and really trying to make a difference here and understand best how we can ultimately improve the quality of the care. Next slide, please. So why do we do it? Ultimately, overall, we want to raise the bar. And that's actually what we really are hearing from a lot of our practices, that ultimately these studies help them really overall look at the quality of the care that is being given. Because again, sometimes the practice itself is where we're doing the intervention or making the change. And so any patient that comes into that practice is going to be benefiting from the research that's going on. So we want to get our results from our research studies into routine practice. And there's different theories out there. Some say that it takes 13 to 15 years. Some say it takes up to 17 years from a research study result to really get into routine everyday practice. That's too long. That takes too long. And so we are really trying to say, how can we move this faster so that we can get these proven results into the routine practice? Ultimately, it improves quality of care. All the boats rise at the same time. So when you're doing it in one part of your cancer center, often we will hear that there'll be quality initiatives that will try to improve this at different practices in the cancer center as well. And then getting that guideline consistent care. When there's national guidelines out there, it's important to you as patients to be able to make sure you are receiving care that is consistent with the guidelines. So what can we do to help our clinicians in our practices design interventions or models for these care so that we can make sure that they are delivering that guideline concordant care? Because it's really, really important. Next slide, please. So as we wrap up here, I think one of the things as I finish this presentation is just to really stress we're doing something different and new, and sometimes patients get approached for a study, and actually we'll be saying that this is a study that's being done in your practice. Are you willing to provide us some data as to how you think this may have benefited you, or what the effect might have been, whether it's been a benefit or not a benefit at all? Sometimes you're just contributing your data to see if what's happening around in the practice has mattered. I know that the team in Des Moines has participated in a couple of different studies. One was looking at smoking cessation for individuals who came in to have a low-dose CT scan because they were being screened for potential lung cancer. And at that time, we looked at what are some opportunities here to help with some smoking cessation opportunities. So that was a study where the research team came out, worked with the teams, and talked about what can you do in your community to leverage some of the things you've got going on. And then another study is a head and neck study that is really trying to pull together a lot of the different team members that head and neck patients see, so that it all comes together in a special care plan for that specific patient, and pulling together this tool. Is this tool effective? Is it helping the practice? Is it making the care more coordinated? So it's an example of a couple of the studies that you may have heard of or that you may have seen as you've gone through your treatment in Des Moines. So I'm looking forward to hearing from the patients and talking tonight to see what their thoughts are about this type of research.
Great, Kate. So I'm going to put the slides down and we're just going to have a bit of a conversation. Thank you for that background. I think one piece of information that's important to share with everyone is a lot of people think, okay, clinical trials, research for cancer, you have to go to a university in order to participate in the clinical trial. 85% of cancer patients in the United States are treated in community cancer centers. And if we only did clinical trials at the university centers, we would be limiting clinical trials to 15% of the population. And the speed with which we'd be able to actually get the trials accrued to, complete the research, get the results would be slowed down tremendously. So it was with great foresight that the National Cancer Institute several decades ago realized that if we're going to improve and increase and speed up cancer research, we need to be able to provide that to the communities. And over time, the programs have become what we now call NCORP. A great opportunity for the university centers to be instrumental in designing the treatment. But as Kate pointed out, they have to be practical. At a university hospital, they have, because of all of the basic science research, a lot more personnel to be able to conduct the studies. And when we bring those studies into a community setting, we have to make sure that they are practical enough that they really apply to the real world, because that's where, and by the real world, I mean the community cancer centers where ultimately the care is given. So it becomes a give and take. The individuals and researchers at the university centers and the base research bases are instrumental in coming up with the design, but we in the community interact in a way that makes sure that the trials, once they are written and released, are done in a way that are practical for those of us to carry out in the community. So that's first and foremost what I would say. And it's been really exciting. I would say that for a community cancer center to participate in a National Cancer Institute research program is a huge commitment and a dedication to quality and excellence. It is much easier and frankly less expensive for a small cancer center to just do standard of care treatment. But the commitment that the physicians, the staff, and the organization has to do clinical trial research really is an indication that you're at a cancer center that is committed to excellence, not just to the business of doing medicine, but to improving what cancer care can be. Kate, maybe ask you to comment further about how you see the role of those community cancer centers who are part of NCORP.
Absolutely. So I'll also add, Dick, that if we only did this research at academic centers or NCI designated cancer centers that are terrific places, as you say, there's a small percentage of the patient population that would be able to go to those centers to do that, to participate on that research. And that makes the studies, then the results, not as generalizable. You need to have everybody, all comers, have the opportunity to be screened and determine if they might be eligible and offered these studies so that it can better represent the population. And that gives us more solid results for these studies as well. So the early research and the basic science being done at the academic centers is terrific. But then as we move this forward and get it out into the community setting, it is so important to have the opportunity to do this in the community setting. And I think the National Cancer Institute really recognized decades ago that when we train clinicians to be oncologists, many of them who come through the National Cancer Institute, as you did, Dr. Deming, that is the model that we use, and they go back to their practices and to their settings, and they want to continue to do this research. They want to be part of the research that has really driven a lot of our cancer treatments over the years. And so it was so important to build these community programs to make it so that our clinicians could continue to participate as they were trained to be innovative and learning and always looking for new opportunities to be the best care for their patients.
Yeah, that's a great point. I can think of when I came out of my residency, and there's sort of this dichotomy: do you stay in academic medical, or do you go into private practice? And there was all of this thought that the pure noble thing to do was to stay in academia, and that to go into a private practice was perhaps to be not as interested in furthering the profession. What the National Cancer Institute Oncology Research Program, Community Oncology Research, is allows those of us in the community to continue to sit at the table with university oncologists, to be actively engaged in designing and to be able to offer our patients in community cancer centers the same National Cancer Institute clinical trials that are offered at universities. So that's let's pivot a little bit and talk some more about cancer care delivery research, because this is really different and takes a bit to get your head around it. So maybe we'll compare and contrast it to a more common sort of clinical trial that we might call a treatment clinical trial. So for example, through the National Cancer Institute programs, we have a clinical trial for women with triple negative breast cancer with positive lymph nodes, and the standard of care is a chemotherapy regimen. The experimental arm is the same chemotherapy regimen, but adding up front immunotherapy. So immunotherapy, exciting new treatment, has been proven to be effective in improving the outcomes for many types of cancer. But right now, the role of the immunotherapy in breast cancer is still being sorted out. So a clinical trial for treatment might be standard chemotherapy versus standard chemotherapy and immunotherapy. That would be a classic sort of cancer treatment clinical trial. The cancer care delivery studies are not so much looking at various ways, various different treatments for the cancer itself, but as the name implies, how does the institution deliver the cancer treatment? So Kate alluded to a head and neck cancer study. Many of you in the audience may know that patients who go through head and neck cancer treatment often have surgery and chemotherapy and radiation therapy, highly effective, but there are a lot of side effects, both while patients are going through the treatment and side effects that show up years later. So the study that we're participating in is we as a cancer center are randomized to be either the standard arm, meaning do your cancer treatment and your survivorship care just the way you've always done it, or a experimental arm where the cancer center and the patients undergoing the survivorship care will be given specific guidance on what to look for, how to ask patient questions about the side effects, how to manage the side effects, ultimately to see whether this more robust prescriptive way of doing follow-up care provides better outcomes and improvement in quality of life. So instead of the patient being randomized to treatment A or treatment B, the cancer center is randomized to do the routine, follow the guidelines as you see fit, versus this focused intervention where, through the help of individuals that are trained in the survivorship, actually coach the cancer center to do a more intense type of survivorship. So that's one example of cancer care delivery research, and we here at MercyOne and CHI are participating in that particular study. Kate, Kate, do you want to maybe also present another classic cancer care delivery research and how it works in real life?
Sure. So I think you did a terrific job describing that. And so in a regular trial or a treatment trial, as you said, there would be standard care or the control group, as we would refer to it, and then something where we're doing something extra. Sometimes in our cancer care delivery studies, as you said, many times we randomize the entire practice. So everyone coming into that practice is going to be getting the effect of the intervention. And we may be asking clinicians to fill out surveys. Some of the clinicians might participate in focus groups where we determine, what has been beneficial, what are the barriers to you doing this, what are the things that didn't work out well, what are the things that did work well, what works within your system. And as we talked about, things need to be practical. We use the word pragmatic a lot. Things need to be practical and doable. So maybe using this head and neck study as an example, you might say, oh, this was great, except we can't do all of this. This might be too much. So through the research that you're doing, they might say, we can scale this back, but these are the key elements that really need to be in this, and then make that more practical to be done throughout the whole care delivery system. We do have some studies where all of the sites or practices that are randomized start together as not getting the intervention, and then they're staggered out along the way, and it's called stepping them, step wedging them. And so each of the practices serves as their own control, so that you see what's normal there, and then at a certain period in time, they cross over to the group that's now getting whatever that intervention is. And that is a very, specific to cancer care delivery sort of work and implementation work that we do, because the practice serves as its own control. It would be like a patient starting on a therapy for a few months and then later on adding on the other therapy. That's not how we do it. We randomize that in a completely different way. So having the practice be the unit of randomization is quite unique to us. And then sometimes having the practice serve as its own control and crossing over is another thing that is really something quite unique to what we do. And some of the topics that we address, again, the financial hardship topic, that has been something that when that first came forward, a lot of our practices said, I'm not sure if we should be approaching patients with these questions. I'm not sure patients are going to want to tell us if they're experiencing financial hardship. And what we heard from many patients and many of the advocates that worked on designing the studies, they said, why don't you ask us? Why don't you let the patients make that decision? Approach your patients about the study and let us make the decision of what we want to share instead of you assuming. And that was very eye-opening to us as a clinician. There were just, it was a change, kind of a changing moment for us. We have some studies that we've got a study open right now where nurses who are working in the oncology area are the actual study subjects, and they are going through extensive training so that they can deliver some early palliative care interventions to patients. Still working along with a palliative care team, if you have a team at your center, but that nurse is really on the floor or in the infusion center in the clinic area, and now will have these skills to then share with their colleagues and have that innovative higher level of practice be available for all patients coming into that area. So there's some examples of some of the different ways that we're doing the research, and some really exciting studies, some telehealth work that's going on as well, how to address distress in patients who aren't going to be able to come in frequently to see a therapist or might not have access to a therapist, but could use a telehealth approach to get this care delivered to them.
Great. And Kate, you mentioned palliative care. One example that, and this was done before we started doing what we call through the NCI cancer care delivery research. So, but it's an example of what it could be. And that was a study about 10 years ago that was published on bringing palliative care into the cancer center. And it was for stage 4 lung cancer. And the intervention was both arms of patients were randomized. All of them had stage 4 lung cancer, which is an incurable disease, but one which is treatable. and they were randomized to two groups. Group number one, the cancer doctors treated them the way they thought was best to treat them in terms of surgery, chemotherapy, or radiation. And group two, the cancer docs treated them the way they thought it was best with surgery, radiation, or chemotherapy. But group number two had a palliative care expert as part of the team from the very beginning. So the actual way to treat the cancer cells was still left up to the individual doctors. The difference was, do you have a palliative care team member on the team from day one? Everyone expected, knowing what palliative care can do, that the group that had palliative care on the team would have improvement in quality of life, and that was true in every measure of quality of life. But what was surprising, and you would only find this out by doing the study, is the group that had a palliative care team member on the team from day one had a statistically significant improvement in overall survival and a decrease in the cost of care. So you only find out that information by doing a study. And again, it's sort of a classic study where you're not mandating what the cancer treatment is, but you're looking at how the care is delivered, and delivering cancer care to stage 4 lung cancer patients with having palliative care on the team from day one makes a huge improvement in the quality of their life and in the overall outcome.
And that's a perfect example then of, you take that research and then you say, not every place can have a palliative care team or a team that's available to patients every day. So now you move forward with these studies that have tested models of delivering early palliative care interventions to nurses to understand how to do this, and then be in collaboration with that palliative care team, sort of that front line or that first stop, and saying, yep, this patient needs to really get on to see palliative care. So building on that work over the decades.
Great. And Kate, how have you seen research change over your 30-year career, and especially since you've been with the NCI through both the Community Cancer Center program, the NCCC, and now the NCORP, the National Cancer Institute Community Oncology Research Program?
Well, I would say over my career, I was a bone marrow transplant nurse for many years, and now they don't even do bone marrow transplants anymore. I mostly do stem cells, but it's immunotherapy in a whole different world. So the changes in how we deliver our care are amazing. As an oncology nurse, I used to give about 15 drugs that I just knew. These were the chemotherapies I knew well. When rituximab came along, that was a really big deal. We're moving out of the chemotherapy realm into immunotherapy. And now one of the areas that I work on in my research is looking at oral anti-cancer agents. And it is such a difference now, because I used to have a patient that sat in the infusion suite, and I could see them for hours, a couple days in a row, every 3 to 4 weeks, and they would come back every week to get assessed. And now that same patient may be getting oral chemo or oral immunotherapy treatments and targeted therapy treatments, and consequently, it's great that they can get oral care and not have to come in and out and take these treatments. However, how am I making sure that I'm doing the education, that I'm assessing the side effects, that I'm monitoring symptoms? How am I providing that support that I normally did when I saw the patient? That's a different model of care, and I know systems are really looking at how we can do that. So that's one of the things we actually are studying at the NCI, is what are optimal ways to make sure we are supporting patients who are getting these oral agents. In the cancer realm of the community side, when we were back in what we called the NCCC, the studies that we did really involved big data. You probably remember, Dick, we had some studies that were done with the rapid quality reporting system through the American College of Surgeons. So our centers reported into that, and then we looked at that data. So it was much more large data sets. And now we're doing true intervention studies where we're coming into those care delivery systems and those practices and making those changes. And we did not have clinicians participating in studies a couple decades ago. It didn't happen. And now, again, we're really having the clinicians be our participants and telling us this isn't going to work. This is a barrier. That's a facilitator. That's a good thing. So that's really been some big changes for us in the last 10, 15 years.
And Kate, I would agree with that, 32 years ago, when I began at MercyOne Cancer Center, we were participating in the CCOPs, and we were kind of regionally located. Most of our clinical trials came through the Mayo Network in Rochester, and it was kind of a little bit like pulling teeth to get all of the community physicians to really buy into participating, because it takes a lot longer to spend time going over clinical trials and getting consents than just doing standard of care. And what I've seen over the last 30 years is now the young docs coming out of training really are embracing the participation in clinical trials. They understand that it is really essential to be a cancer center that is paying attention to quality and excellence and offering the patients all that they can get. And part of it, you were being sort of prompted by some of the university cancer centers that are spreading out and moving and collaborating with other centers around the country. And if you are a community cancer center that doesn't do clinical trial research, most people would say you're probably not at the top of your game, and that you don't have as much dedication to quality and excellence as those community cancer centers that take on the extra burden, both in time and expense, to be able to develop the research programs and to offer it to their patients.
Yeah, and I will give credit also to the American Society of Clinical Oncology. They really, maybe 15 years ago, started the quality improvement initiatives and started some of the programs where practices could be participating in this initiative called COPI. That was some of the work we did in NCCCP, was we looked at this quality data that our practices had. And I think as a professional organization, that sent a very strong message to say, quality is the foundation and it's the basis of what we need to do. And I think that was a really strong positive reinforcement to this is where we need to go with the work.
So Kate, we're going to open up to questions from those here in our live studio audience, and any questions that come through the chat box. So we'll open it up to questions. Any brave member here? Questions? Anybody in the room participate in a clinical trial? So as Kate mentioned, not all clinical trials are about treatments, and there are some symptom management clinical trials. So I know that many of my patients, some of you might have participated in a neuropathy clinical trial. So peripheral neuropathy can be a common side effect of chemotherapy. So we have trials that are looking at how can we minimize neuropathy. Many patients also know what it means when you say chemo brain. So we have some clinical trials that are looking at how can we mitigate some of the effects of chemotherapy on cognitive function.
Is there a number of trials that you're doing here at MercyOne? So do you do do you have 10 ongoing now, or 20, or how's that working right now?
So the question is, how many clinical trials do we have open here at MercyOne Cancer Center? So I would say approximately 60. So it is a large number of clinical trials, and it spans all different cancer types, from lung cancer, breast cancer, prostate cancer, colon cancer, head and neck cancer, pretty much you name it. And it spans from treatment trials to prevention to screening trials. For example, we're participating in the National Cancer Institute's randomized study looking at 2D mammograms versus 3D mammograms. So that is a very large screening trial conducted through the National Cancer Institute that's around screening, which is obviously early detection. And then, as we've been talking about tonight, it also includes cancer control and symptom management, as I mentioned, neuropathy or cognitive dysfunction, and then the cancer care delivery. So a large number of studies. And for us to be able to do that, we have at MercyOne Cancer Center 3 clinical trial nurses and also an administrative lead in order to make sure that we're offering the appropriate patients, the appropriate trials, and then tracking the results, tracking that the trial is being done exactly the way the protocol states, and then following up with the results, and all of that getting reported back to the National Cancer Institute. A lot of time and energy, yes, yes.
So we just contact MercyOne.
Yeah, so how do you find out about clinical trials? That is a great question. So it is very appropriate, and I would actually recommend it, that any cancer patient seeing their cancer doctor ask, am I eligible for a clinical trial? You may or may not be eligible, but making the physician aware that you know about clinical trials is good to do. They will often talk with you in more detail about what are all of the options. So every physician does that, but many times we tend to take the most expeditious route, which is sort of thinking about offering the most standard of treatments instead of necessarily having a conversation with the patient about shared decision making and standard versus experimental, and which way of treating the cancer makes the most sense from a patient perspective. So number one, asking your doctor. Number two, there is a wonderful website, clinicaltrials.gov, that is on the part of the National Cancer Institute website, where you can see all of the clinical trials. You can type in your type of cancer, your stage of cancer, and you'll get a list of all of the clinical trials that are being done in the country and where they're being done at. So you can do that on your own. You'll often hear a patient say, oh, my doctors tell me don't go to Google. Well, I can't imagine anyone living in this world nowadays without using the internet. But the important thing isn't that you not go to the internet, but that you go to reliable sources. So cancer.gov, a very reliable source for good information. Cancer.org is the American Cancer Society, another great resource. But if you want to look up and see if there are clinical trials for your particular cancer, the clinicaltrials.gov, part of the National Cancer Institute website, is a good way to do that. Kate, I'd welcome your thoughts on other ways for patients to look at clinical trial possibilities.
Clinicaltrials.gov is a great resource, and you can sort by state as well. So once you put in your your diagnosis, you can put in states or regions of where you're interested in. We also have the Cancer Resource Network, and so you can, when you go on clinicaltrials.gov, you'll see where you can call. You can actually talk to someone, and they're very beneficial. They can provide information to you. There's a lot of information on our websites about cancer screening, as well as cancer treatments themselves, the different stages of cancer, all of that sort of thing. And as you say, a lot of effort is put into making sure that it's updated information, and it includes the most recent information and evidence. So we do update those sites on a regular basis.
So in this day and age, in the 21st century, it is much easier for doctors and the team to know the guidelines and follow the guidelines because they're updated in real time by going to the website with the guidelines. You know, we used to practice medicine by textbooks that got published, you know, every 5 or 10 years would be updated. We used to have to go to a library and use the card files to look up journals to actually access the journals. I'm old enough to know that, and to expect physicians that are in practice that are out in the busy world to take time to actually go to a physical library and get the articles and Xerox them and read them. There's no wonder that it took 17 years for new guidelines to get into the real world. Now, I would say that my experience is that the guidelines, we are adapting to them much more quickly because every single one of us carries in our pocket, you know, access to every guideline in real time updated. So that's been a real improvement. One other thing that I wanted to ask you about, Kate, is, you know, a patient-reported outcomes. So we now have the ability, not all of us are set up to do it, but there is the ability through technology not to wait till the patient comes in 3 months from now and ask them in person about side effects they're having, not waiting for them just to call and leave a voicemail and try to get back to them. But now there is technology that allows patients to report outcomes, whether it is side effects or other symptoms they're experiencing. And that's being incorporated into research. Care to say something more about patient-reported outcomes and how telemedicine and electronics are being used to harness that power?
Yeah, so we have done a lot of work, and I know within NCORE, the research bases have done a lot looking at patient-reported outcomes and different methods. So as you say, the smartphone, a great way to do this through apps, but also people can do it through voice response. So what we call IVR systems, you can go to just a regular phone and push 1 if you're this, push 2 if you're experiencing that. And it's a way for people to report in their own time. So it doesn't have to be I'm at the doctor at 9 a.m. or I'm calling the nurse at 10:30 because I know that's when they're right before they're going to go to clinic. It can be when you have time, you use it, you get prompts to remind you. And so part of the research that we're doing now is what happens when that data comes back into the clinical area? How do we manage it? Because there's a lot of data coming in from a lot of people, and how do we make sure that we're responding to it? So I think we're finding that there was a lot of work done with a system called ProCTCAE at the NIH in the group that I work with. And there are certainly, when we are looking at patients who are receiving treatments, there are certain toxicities or side effects that a patient may experience that we can see. We can see a lab result, it's an objective thing, or we can see they're having a rash or something. But there's other symptoms and side effects that only the patient can tell us of what their experience is. I can't look at you and tell how fatigued you are. Only you can tell me if you're experiencing fatigue or if you're experiencing nausea. That's something a clinician can't experience for you or really grade for you. So it has been extremely helpful to have some of these symptoms that only a patient can really describe in that experience that we as clinicians can't so easily understand when we objectively look at a patient, to have that be able to be reported. And there are a lot of tools out there. I'd love to hear from some of the people with us tonight, what their thoughts are about apps and responding and such, because a lot of the things we develop, we often question, how long will a patient do that? Can you prompt a patient twice a week to do something, once a week to do something? You know, at what point does it get to be annoying? I'm in a study where I'm doing this COVID thing, and I will tell you it's now at the point of annoying. I don't want them pinging me every day anymore. So it's we're always curious as to what's enough to make sure the patient is engaged, but what's too much. And are things like smartphone apps to remind you to take a medication or to report a symptom, are those beneficial? And do people see those as something that they really find to be helpful to them?
Great. So what do you guys think about reporting your symptoms through an electronic device? Okay. Have you ever done that before? Okay. So the first response was that would be great. Hasn't done it before.
And I think that if I did it, that it would be great for like a week, 2 weeks, or maybe a month, but I might get tired of it, and then now it goes away a little bit.
Yeah. And so you don't want to do it too much, but you like to be able to have that ability to interact.
It's great to have that, if you can record to the doctor what's going on. For example, not up to
And do you guys have difficulty sometimes getting through to a doctor's office? So I would just say one of my pet peeves in life is you can't talk to a human being anymore, and you get voicemail, and I'm not just talking about medicine, but do you find it difficult to get a hold of one of your care team when you have a question? I'm hearing heads shaking. That's what I'm hearing. Yeah. Yeah. Well, thank you for your input. Kate, we're getting to the end of the hour, so I just want to again thank you for participating in our cancer education series. Again, not only is medicine changing, but for 10 years, this cancer education series, everybody had to be in this room in order to participate. And now we get experts from the National Cancer Institute who are participating with us this evening. So I really appreciate your participation this evening. And it's always great to connect with you. So thank you, Kate.
Well, thank you, Dick. And on behalf of all of us at the National Cancer Institute and the NCORE program, thank you and your team for all your dedication and commitment to research. It's because of you that the patients are able to receive cutting-edge therapy. So we really appreciate all the hard work. And
Great.
Thanks everyone for joining tonight.
Thank you so much, Kate, and thank you to everyone for joining us tonight. If you'd like to watch this program again, or if you want to refer this program to individuals who couldn't be here tonight, it will be available on the MercyOne Cancer Center website, and it will also be available as a video podcast on the Above and Beyond Cancer YouTube channel. So thanks again for coming this evening, and please join us again next week. Thanks, everybody.